2017. It was an amazing experience. It actually was my first medical mission, and it developed a love for me to travel across the world to help different countries look after these wonderful children. And as Carrie mentioned, I'm no longer directly involved in cardiac ICU. I now am a neonatal nurse practitioner, so I look after babies from 22 weeks gestation, which is very, very premature, through the entire hospital course. My institution no longer doesn't do cardiac surgery. We do all the pre-management. We move them to sick kids, and then they come back and we do the recovery. So I really like to stay involved in cardiac care because it is my passion, even though I'm not directly in it. And I look for any opportunity that I can continue my own competence. These lectures are great because it helps me remember a lot of stuff, things that I don't always, think about every day. Now I'm thinking about growing and reflux and vomiting and apneas. I'm not thinking about cyanotic heart disease and shunts and lesions and stuff like that. So this was a good review for me, just so I could kind of stay on the ball for this. One of my really good friends was actually a fellow. I don't know if you guys know Winsome Scott, Dr. Winsome Scott. She's a neonatologist down in Guyana and Georgetown. She actually worked with me when at McMaster. So when I come and visit you guys, I'm hoping to see Winsome as well. So today's lecture, we're going to be talking about two specific defects. We're going to be talking about atrioventricular septal defects, and we're going to be talking about tetralogy of Fallot, and we're going to be talking about there's the pathophysiology of these conditions and their surgical corrections. And one of the common complications of both of these surgeries is different type of cardiac arrhythmias. We're going to talk about pacemakers and kind of what to look for when we are looking after these children after surgery. Let me see if I can move this forward. So kind of just to review what I kind of mentioned. So we're going to talk about an overview of both the lesions. We're going to discuss post-operative pacemakers and the management of two specific rhythms, junctional ectopic tachycardia, and we're going to be talking about heart blocks, in which there are a few, and two of them that we're really worried about after surgery. So let's just go through a very quick refresher. I think everyone kind of knows what we're looking at, but this is the normal design of a normal structured heart. We have our two sides. So let me get just a little marker here so that we all know, but I think we all do. You have your right side over here. You have your left side over here. Blood comes through the body, which is from, let me find my laser pointer here. You can see it here. So this is your superior vena cava. This is your inferior vena cava. These are the two large vessels of the body. All the blood of the body comes into these vessels, collects into the right atrium. From the right atrium goes into the right ventricle, in which the right ventricle pushes blood through the pulmonary valve out into the lungs. It comes back through the lungs, through the pulmonary veins, goes into the pulmonary artery, goes into the ventricle, the left ventricle, and out through the body. And this does it anywhere from 40 to 160 times a minute. And it's very, very effective because it was made to be effective. And the main thing that makes the heart the two things that make the heart very effective is the valves. So we have the mitral valve, we have the tricuspid valve, we have the pulmonary valve, and we have the aorta valve. And the reason why it's efficient is because these valves close, allows the heart to fill up with blood. And then when the pressure in the heart gets high enough, the valves open, and then they have a very efficient pumping system. And efficiency is the big key here, is the heart is designed to pump, like I said, 40 to 180 times a minute for 60, 80 years, every minute of every day. And it's designed to be very efficient, so it oxygenates well, it gets rid of metabolites well, the tissue is really compliant, it allows for changes in activity. And a lot of that, again, is because of the valves. And so when you have injury or changes to the valves, the heart isn't efficient and it starts to tire and it starts to fatigue and then it starts to fail. This is an important view to kind of remember. So this is a normal heart. This is what's called the transverse view, meaning it's kind of like cutting the heart in half across the body. And we're taking a look down from the top and we're looking at what those valves look like from the top. So here is your mitral valve. So this is the one that goes into your left ventricle. This is your tricuspid valve. This is the one that goes into your right ventricle. This is your aorta. This goes to the body. And this is your pulmonary, and this goes to your lungs. And the important thing that you can see, hopefully with my marker here, is there is a division, there's a divide. So you have something called your atrial ventricular septum, which is this whole floor that the annulus of the heart, or of the valves, which is like the fibrotic circle that goes around the valves, is attached to the septum, and the two sides are closed. And this is important because it keeps the two sides of the body separate, the right side and the left side. It maintains efficiency. It prevents the mixing of blood that is oxygenated from the lungs and deoxygenated from the body from mixing together. So it keeps the two separate systems working in parallel, separate from each other. And then you will remember, this is just another review, that the heart valves open and close in kind of a sequence. So when the heart is pumping, so the ventricles are squeezing, that pops open your aorta and your pulmonary valve, and your tricuspid and your mitral valve close. The reason for this is we don't want something called regurgitation. And regurgitation means that when a valve closes, but it doesn't close completely, there's a hole. When the ventricle squeezes, blood can, instead of going the direction it wants to go, it backflows. So it goes back up where it comes, and that's not efficient. We want everything to go forward. We don't want anything to go back. So it's very important that these valves open and close in sequence. And when there is injury or changes to the heart that prevents this sequential closing, the heart becomes inefficient. Blood shunts, which means it goes through spots it's not supposed to go. It mixes so that the oxygen concentration decreases. And sometimes what can happen is blood volume that's not it. So the right side of the heart is a low pressure system. So it has a low pressure. The left side of the heart is a high pressure, and when volume moves across this gradient or this change in pressure, it puts a lot of work on the right ventricle that's not designed to deal with a lot of pressure. So that also leads to other complications associated with both of these lesions, and we'll go into more detail because of that. So the first lesion that we're going to talk about is called the atrial ventriculoseptal defect. And there's different variations of this defect, but the design and problem of this heart is that there is this hole. And I think Carrie has kind of talked about ASDs and VSDs with you. Those both lesions can be present in this lesion. So if we're looking at the picture here, you see that there's a VSD here. It's kind of hidden, but there is a little ASD here. And then there's a defect in that septum that separates the top and the bottom. And when that defect occurs, the valves don't grow properly. So they're kind of, we don't even really call them mitral and tricuspid valves anymore, because those terms generally mean formed valves. So in the mitral valve, it has 2 leaflets. In the tricuspid valve, it has 3 leaflets kind of coming together. And when there is a defect, we just call them AV valves, atrial ventricular valves, and we call them left, or we call them right, because they're not morphologically looking like they should. And this goes into the problem that I spoke about before, is now these valves aren't efficient. There's holes where there shouldn't be. The heart is going to pump, but these valves are not going to close. And as a result of this, the heart is not going to get efficient. I have a video. I hope it does work. Let's give it a try. So if you guys have sound on, it should, but let's see if this works. So this is from Cincinnati Children's. And the reason why I included it, it's a short video, but it's 3-dimensional, and it really helps you kind of understand what's going on with this heart. So you don't worry too much about the info. I want more to look at the picture of the heart. So this is just going over the anatomy we kind of discussed already. And this is the common AV valve that I was talking about. And what you're seeing here is 2 valves that have kind of merged into one. And now you're looking from the bottom of the heart, looking upwards, and you can see that this valve is very, like, it's joined, it may not be closing properly. and it isn't really structured the way a heart valve should be structured. And as a result of this, the heart can't direct the blood where it wants to go. So you can get this mixing, which the video is going to show. And as a result of this mixing, the heart has to work harder and it starts to get tired and fatigue. And this is when you start seeing symptoms like breathing fast, poor weight gain, cyanosis. And when it gets to that degree, surgery is what's going to be necessary. So now that you guys got kind of a three-dimensional view, I'll kind of walk through the two-dimensional view because things aren't moving and we can kind of discuss the problems in this defect. So on the top here, you have your normal heart. And as we kind of just pounding it into you guys about the importance of structure. So in the normal heart, you have two distinct valves. You have your mitral valve here, you have your tricuspid valve here, and these have very distinct shapes. The mitral valve is 2-leaflet, the tricuspid valve is 3-leaflet. And this is important because these valves close perfectly and there's no leakage through these valves. That's how evolution has made them, is they close perfectly. And when the heart pumps, they're efficient because they close, they prevent no backflow of blood into the left atrium. It all goes forward. It's a very efficient pumping system. But when these defects develop congenitally, there can be problems in the formation or the morphology of these vessels as well as the heart. So here on the left side where it says partial AVSD, you see that there is an ASD, but these valves kind of look normal, but they are not perfectly normal. So there's these little kind of fissures or little tears on the side of the heart. So what's going to happen is the valves will not close properly. And when they don't close properly, blood leaks through, leads to an inefficient heart. Additionally, because there is this hole on the top, this is your ASD, your atrial septal defect, blood is going to shunt left to right. And we rely on something called an atrial kick. So when our atria is filling up with blood, the moment the mitral valve opens, blood passively goes from the top to the bottom. And then right at the very end of this diastole, this cycle, the atria gives one last squeeze, and this is called your atrial kick. And this pushes the majority of leftover blood of the atria into the ventricle the second before the mitral valve closes. And now this left ventricle is well distended and it can push all that blood out. And that goes through the body, gives you your blood pressure, gives you oxygen, but it has now completely filled up, fully distended, so that when it contracts, it is a very strong contraction. And again, it creates an efficient heart. When you have holes in the heart, you lose that. You lose that atrial kick, and you can lose up to 30% of your cardiac output. It means the heart has to work faster because what was very efficient is not. So to compensate, it goes faster, and this can lead to different kinds of myopathies of the heart, which can lead to heart failure. So partial AVSDs are generally more milder, and sometimes you can be asymptomatic or you can have very mild symptoms, and often these children aren't acutely unwell. However, with the AVSD, now you have a little bit more of defects. You have your ASD, you have your VSD, but now you have a complete hole through both valves that they've merged together. And now that efficiency is going to be lost because this valve isn't designed to close properly together. There's going to be a hole in it, and you're going to get regurgitation. You're going to lose those atrial kicks, and the heart is going to become inefficient. This will lead to heart failure. And sometimes, now in my next slide, I'll go into a little bit detail about balanced versus unbalanced. But these children cannot be actually quite okay for the first couple months of life because the lung blood pressure is still high and it prevents overflow of blood to the lungs. But as that lung blood pressure drops as the baby gets older, then they can start having this over circulation to the lungs, and they can be very symptomatic for that. And they need to have surgery. So this is kind of what we're talking about shunts. So I've drawn a little picture. So this is your different types. So up here is what we would probably call like an ASD. Looks like the valves are kind of formed. Maybe it's a partial, but it's just mostly an ASD. And blood will shunt across generally. It goes from the high pressure to the low pressure. So you lose oxygenated blood, but usually not symptomatic. However, if the blood shunts the opposite direction and you get deoxygenated blood to the left atrium, you now will have a decreased oxygen to your body, and you can be symptomatic for that. Similar thing with like a VSD. If the VSD goes from left to right, initially no symptoms, you should be fine. The baby will not look like they have fast heart breathing, low saturations, poor growth. But over time, this extra amount of blood that is floating into the left or right ventricle will cause the right ventricle to fail. And then it stops pumping well, or gets really, really thick, which is called hypertrophy, or thick, non-efficient muscle. And then blood will start shunting the opposite direction. And this is where you get symptomatic hypoxia, and the babies look blue and they don't look well, and they have very sweaty, and they might be like really not growing well. And then with an AVSD, you can have shunts on both levels. So all of that I just talked about the inefficient hearts, hypoxia, cyanosis, poor growth, can be present in this lesion. So it's a more complex lesion. Now, to even add to this complexity is something called a balanced or an unbalanced AVSD. So in a balanced AVSD, that AV valves, those like left and right AV valves, sit over both ventricles equally. So they're balanced. And while there is a hole in the heart, the balanced nature of the valves will mean that as the ventricles push, blood will generally go where it needs to go. There might be mixing, there might be some decreased saturations, but the perfusion or amount of blood to the lungs, to the body, is generally okay. And these babies can be well up to 6-8 months, sometimes even longer. And they might be a little fatigued. They might not have as much endurance. They might sweat more or not grow, but they survive. What gets more concerning is when we have an unbalanced AVSD. And so this is where that common AV valve, so that malformed valve, sits more over one valve than the other. And these can kind of present themselves as different types of cardiac lesions. Something that you may have learned about, but we call something called single ventricle physiology. It means where there's just one dominant valve or not one dominant ventricle, the other ventricle doesn't work well. And depending on which valve doesn't work well, the symptoms can be varied. But this is usually a much sicker child, and this child will usually need surgery pretty quickly, or they will die, unfortunately, because their hearts will not be pumping well. So there is different approaches to how to fix these lesions. And I'm going to probably talk about the main one, but sometimes depending on the children that you see on these missions, they may have some sort of variance to these. Sometimes it can be a temporizing surgery. It might be a surgery that's only possible to give them a little bit longer life. It may not be curative, unfortunately, because the heart is not growing the way it needs to grow for a full repair. But I'm going to talk about what happens when we do a full, complete repair and the whole heart is returned to its normal physiology and structure. So it actually is kind of simple, but kind of not simple. The simple answer is you just plug the holes. You just close where these defects are and you just patch them up. And once they're patched, everything looks well. So the first thing that the surgeon will do is the surgeon will open up the heart, usually from the right atria. they will look down this hole and then they will patch the VSD. And they literally take, it's called Gore-Tex generally, and it's just like a synthetic material that's like waterproof. And they just cut it out and they measure the size of the hole. And then just like suturing a patch on clothing, they just suture around it until that hole is closed. Then they do something called a valvuloplasty. And plasty usually means like surgery to fix something, and valve means a valve. And what they will try to do is they'll try different methods of restructuring these hearts or restructuring these valves to look like they should. It's not often perfect, but it's good enough that the regurgitation or the backflow is minimal or not existent. They will never have a full tricuspid or mitral valve, but they will have valves that work. And so again, we call them a right AV valve or a left AV valve, and then they'll have a valvuloplasty. And so this is when the picture kind of says 2 new valves. They're not really new valves. They're rebuilt valves of the patient's own tissue that had like plastic surgery to make them look properly. And I got another picture that kind of looks at this a little bit better. So here you see the patch. So there's a patch that closes the ASD, and there's a patch that closes the VSD. And then you see these little sutures here. They've kind of tightened up those valves. They made them not leaky, and now the valves close. And what the surgeon does is during the surgery, there'll be a cardiologist in the OR with him, and then they'll do an echocardiogram. So that's like an ultrasound of your heart, and they'll test that the valves work. And there's different ways of doing that. But then once they're making sure that the valves work the way they want, they're happy, or they get as little regurgitation as they want, and then they know that the heart's working well. And so that's why it's like a 2-person approach. The surgeon does the surgery, the cardiologist checks the function, make sure everything looks well, and then they can close up the patient. Sometimes they have to use 2 separate patches just because the septal defect is a little bit more complex. So they cut a little one on the top and a little one on the bottom, and then they do some work on the valves to close them. And in some cases, they just need to use 1 patch and they just close everything up. And again, what happens now is you now have no leaking at the bottom of the heart, you have no leaking at the top of the heart, and you have no regurgitation of blood from the ventricle. The heart is structurally normal, and these babies should now be quite well and good and not have a lot of problems if the regurgitation is minimal and the ventricles are a good size. So these surgeries, you have generally very good outcomes, and these children live very normal lives as long as the heart is structurally normal. Now, the next heart defect that I want to talk to you guys about is something called a tetralogy of Fallot. And Fallot was a doctor hundreds of years ago who noticed that babies had 4 specific lesions of their heart, and he called it a tetralogy, or like 4. And Fallot, he obviously put his name on it because he wants to be famous. And this is a lesion where we see that these babies have, as I said, 4 distinct features of their heart. And here are what those features are. So the first feature that they have is they have a VSD. So just like the AVSD that we just talked about, there's a hole in the ventricle. And that means blood can mix between it, and the heart's not efficient because the 2 chambers aren't separate. Because this in utero, so inside the mom, this is happening, all this extra blood flow that's cycling into this right ventricle makes this ventricle very, very thick. To worsen the thickness of this ventricle, there is also a stenotic pulmonary valve. Stenotic means narrow or tiny. So this ventricle is trying to push blood forward, but it can't because this opening is so small that when you get this kind of force, the ventricle gets thick and thick and thick, and it doesn't pump as well. And then the last one is what we call an overriding aorta. So the aorta is the large vessel that goes to the body. It takes all the blood from the left ventricle and pushes it out. It's usually faced a little bit more towards the left ventricle, kind of sitting on top of it. In the tetralogy of Fallot, it kind of moves center and it overrides the hole that's caused by the VSD. And it means that blood can go from the right ventricle through the VSD out through the body, and then this person will be very cyanotic. And because this hole is so narrow, blood likes to flow the path of least resistance. It's like a stream. If you have a fork in a stream and the stream goes in two different directions, water will flow with the least resistance. And in this lesion, what will happen is the blood will decide to go towards the aorta, meaning that the lungs don't get enough blood. The body gets deoxygenated blood and the baby will be very cyanotic. And in some cases, and I'll talk about it very in my next slides, they can get no blood to their lungs, meaning there's no blood returning, there's no oxygen, and they can die. So that's something called a TET spell, and I'll go into a little bit more detail of that. Because I like colors, and I just wanted to kind of give you another thing. This is a similar picture as I had before, but now you can actually see this mixing of blood. So you can see blood comes back from the body, goes into the right atrium, comes back from the lungs, but this mixing occurs here. A lot less blood goes through the pulmonary artery because it's so small. More blood goes through the body. And at the end result, you see that most of the blood going to the body is purple or deoxygenated. So the baby will have saturations in the 80s or 70s. They will be breathing fast. They will look cyanotic and blue. They might sweat more, and they might breathe faster because their body's trying to oxygenate the little bit of blood that they have going in. The one thing that I just want you guys to be paying particular attention to is this right here. So this is called a patent ductus arteriosus. Every baby has it. It's a intrauterine shunt. It's designed for the body to bypass the lungs when the baby is inside the mom because they're not breathing, and it lets blood go to the body. In some children, this PDA or patent ductus arteriosus stays open. And that leads to a whole bunch of problems for some babies that have PDAs all the time. But in tetralogy of Fallot, it's actually life-saving because what happens is the lungs don't get enough blood from the heart or from the right side of the heart, but they get an extra bit of blood from the left side through this pathway. And so they can actually survive quite long. And this is important because when they first invented the surgery for this condition, the surgeon who kind of came up with it looked at the babies he was looking after, and he noticed that the babies that didn't have this PDA died, and the babies that did have this PDA lived. So he said, well, clearly having this extra pathway of blood to the lungs keeps babies alive. And so he came up with a surgery, and I'll explain it in my next couple of slides, that was used as a life-saving measure for a lot of these children until a more better surgery was invented. And I'll explain that in my next slides. So I think I got another video here, if this one works. And this is just going to kind of go over the same thing I discussed again, just like the last video. And so this is what I was talking about, both the tetralogy, the VSD, the overriding aorta, that narrow pulmonary valve, pulmonary stenosis, and the thick right ventricle. And now you're looking from the bottom of the heart looking up, and you can see that there's this VSD, which the video shows, and that's that connection. That's kind of important. I wonder if I can show that. So this is your pulmonary artery. This is where blood is supposed to go out through the body, or sorry, to the lungs. So this is your big valve to your lungs. But you can see, because that valve is so stenosis and there's such narrowing, you can only see a very, very little bit of the pulmonary artery. But what you can see more of is right here. Oh, you can't see, or I can't see my points right here. So this is your pulmonary artery. It's very, I can't, I don't know if you guys can see my, I'll show you on another one. Unfortunately, I don't think you can see my laser pointer on this one. We'll finish the video and then do it. So the blood's obstructed. You're not getting blood to the lungs. It's going to prefer going to the body through the aorta. And as a result, the right side gets really thick. And there's mixture of blood, so the body gets deoxygenated blood. And that deoxygenated blood makes them very blue looking or hypoxic. And so one of the characteristics, and I actually saw this a couple times when I was in Guyana, is something called a TET spell. And you guys might have seen this as well at times. So it's categorized as a hypercyanotic event, where the baby's lips go blue, they look blue, they sweat, they breathe fast, and it usually happens when they're upset or crying. So they look then they might pass out. And when they pass out, they might go to the floor and then they wake up again. And what's happening is, over time, there is narrowing, further narrowing of the right ventricular outflow tract. And what that is simply the passageway to the lungs through the pulmonary valve, because the heart's getting thicker and thicker and thicker. And the area around it, called the infundibulum, is getting thicker and narrower and narrower. So blood is going to be less likely to go to the lungs. The blood is going to want to go to the aorta. And what now also happens is, as the right side gets thicker and harder, it's going to start pushing blood in the opposite direction across the VSD into the left ventricle. So the baby's going to get more cyanotic. And so when the baby is feeding, when the baby is crying, when the baby's angry, what happens is they get increasement of epinephrine. They get the stress response. They're mad. And so the epinephrine that circulates through their body, and the norepinephrine, makes the heart beat faster, and it makes it beat like harder, and it worsens this obstruction. So they get more cyanotic, and then they get more passed out. And this can continue to the point that there can be no blood flow going to the lungs and the baby can die. So what you notice is some children are really smart, and they realize that, oh, I don't feel well. And that they will squat, or they will sit down kind of in like a squatting position, because they learn that when they squat, they feel better. And so what's happening is they are increasing their SVR, their systemic vascular resistance, and they're decreasing the blood flow going back to their heart. It's a vagal response. And what happens is then blood can easily go to the lungs versus the aorta. It shunts the way it should go, and they feel better. So sometimes you see these children, they walk, and then they stop and they squat, and then they walk and they stop and they squat. And what they're doing is they're preventing the TET spell. They're pushing blood to their lungs. They feel better. And I remember when I was in Guyana with you guys, there was a child, he was kicking a ball, and he kicked the ball, would run, squat, kick the ball, run, squat, because he was having very mild TET spells. And then once we did the surgery and everything was fixed, He didn't do it anymore. So I think he still did it because he liked doing it, but he didn't do it because it made his breathing easier. So when these children are having something called a TET spell, we got to do some sort of treatment for them. And these are usually the kids that are sicker that need surgery sooner. So one of the easiest things is you calm them down. You get them to be quiet. You comfort them. You give them a soother. You give them a lollipop, or you give them medication to calm them down. So you give them morphine, or you give them ketamine, or you give them fentanyl, or you give them midazolam, and you knock them out and you get them calm. You can mimic that squatting effect. So you can put the patient's chest to knees. That increases the SVR. That allows blood to go to the lungs. You can provide oxygen. Oxygen dilates the pulmonary vasculature. It allows blood to get more easily into the lungs. And then you can artificially increase the blood pressure, which will push blood back into the lungs. And what you do is you give them medications like phenylephrine, which is a very, very potent vasoconstrictor, and you push it and it increases it. Treatment long-term for these children is you put them on beta blockers. So you put them on metoprolol or propanolol, but in the immediate emergent time, you give them a medication like esmolol. And it relaxes the narrowing around the pulmonary artery. It relaxes the heart. The heart doesn't beat as fast. It gets more efficient, and it temporarily fixes the symptoms of these cyanotic TET spells, and you have babies that can wait until surgery. There's also an opposite phenomena that occurs sometimes in these babies. I'm just going to go back to the picture of the lesion so that you guys can see. So what can also happen is sometimes you have, so what I was talking about, these cyanotic babies, is we cutely call them blue TETs. They're blue TETs because they look blue. On the flip side, you can have babies that are pink TETs. And what that means is the narrowing here in their pulmonary artery isn't as bad as, it's not as bad. So what happens is blood decides to go through the ventricle to the lungs instead of the aorta, and they actually get overflow. They get too much blood to their lungs. So they get pulmonary edema, they get frothy secretions, they have poor exercise reserve, and these babies will not look cyanotic, they will not look blue, they won't have TET spells, but their heart is still failing because these holes are causing that inefficient shunting of blood, overloading the right ventricle, overloading the lungs, and they need surgery because they're getting too much blood to their lungs. So the question now is, well, what do we do about this? How do we get this? How do we fix these children? And so there's different surgeries that are available. The first one is called a BT shunt, or a Balick Taussig shunt. And it's named after a surgeon and a female cardiologist who together realized that the babies with that PDA, or that connection between the aorta and the pulmonary artery, lived, and the babies without that PDA died. So they said, well, clearly the babies get extra blood flow to their lungs from this shunt. Well, how do we make it? And back then they didn't have bypass surgery, so they had to do it on a beating heart. And so they said, well, what can we do on a beating heart? And the answer was complex but simple. They created a tube, a straw. They sewed the straw to the one part of the heart, somewhere on the aorta, and they put blood into the lungs. And it didn't matter that this was oxygenated blood, because it wasn't necessarily the oxygenation that was the problem. Even though these babies were blue, it was not enough blood going to the lungs to get oxygenated to oxygenate the body. And so they came up with this surgery, and they put it on, and they put it on the pulmonary artery, and the lungs got extra amount of blood, and the babies lived. The problem is, this is short term. Babies will grow, children will grow, they will get bigger. This shunt doesn't get bigger. So if a 1 centimeter tiny shunt is fine for a baby, an adult needs a shunt like this big. It needs like a 3 centimeter, 4 centimeter shunt, and you can't keep going back and fixing it. You need to do something else. So as cardiac surgery become a more advanced and more innovation came, they came up with the heart-lung machine, the bypass machine. And with the bypass machine, they could stop the heart, and then they could actually do a full repair. And that means fix everything. So the next surgery is the complete repair. Similar to the AVSD, the surgeon will open up the right atrium, will look down through the tricuspid valve, and will patch the VSD. So now that closes. The pulmonary artery is still narrow, so you have to open it up, and there's different methods of doing that. But one method is something called a transannular patch. So they cut open the pulmonary artery. So if it's really narrow, they cut it open, and then they put a patch on so it becomes wider. And as it gets wider, it now gets rid of that stenosis or that narrowing going through the pulmonary artery, and that the heart now doesn't have to beat against this obstruction. So over time, the heart relaxes and normalizes and gets to a normal shape again. And with the VSD going around the aorta to kind of line it up better with the ventricle, you've got rid of that overlying VSD. And so now the heart is structurally normal. And this is a complete repair. And then once the babies have this surgery, they will live their entire lives. And on one of my medical missions, when I was in the Philippines, I actually met a man. He was in his 70s or 80s. He was one of the first children to get the BT shunt, and his surgeon was Ballack. So the guy who invented the BT shunt. And he got that surgery when he was about 2 or 3. And he lived. Then when he was older, he got this surgery. So when he was about 15, he got this surgery because they invented it. He was born during a time that this surgery didn't exist. So he got the shunt to keep him alive. And then they invented the full surgery and he got it done. And like I said, now he's in the 70s or 80s, living in the Philippines, still healthy, says his heart's working good. And he's kind of like, a miracle that everything's working great. The interesting thing, though, is despite having the full surgery in his teens, if you look at his fingers, he has full clubbed fingers still, because the period of hypoxia prior to surgery was so profound that he got clubbed fingers that you might see in people with like heart disease or COPD or any of those kind of adult conditions. So it still stayed with him, but he's alive. And it was quite remarkable to meet someone like that. So as you guys can tell by now, I like videos. So I got a video of the surgery. I think this one's really good. I really liked it because it really conceptualizes what the surgeon's going to do. So this is, again, looking from the bottom. This is the narrowing in the top that you see is obstructing the pulmonary artery. The surgeon cuts some of that obstruction away. They put in the patch to close that VSD. And now they go to the pulmonary artery. And this is what I was talking about where they do a patch. So they cut it open, take out that extra tissue that they don't need, makes the hole bigger so the blood flows to the lungs easier. And now they put a patch on to open up the diameter of the pulmonary artery and to get rid of that obstruction. And now you can see that there's no mixing of blood, and blood goes where it needs to go. And so this is just kind of a summary of everything we discussed already. In the top here, we have our normal heart. Everything goes where it needs to go. Here we have our tetralogy of flow. So we have the thick right ventricle, the hypertrophy, we have the VSD, the aorta is overriding the VSD, whereas here on the normal heart, it's lined up perfectly with the left ventricle. There's pulmonary artery stenosis. and it's much inefficient pump. The temporizing measure is the BT shunt, which will prolong life, but it's not a cure. And then the full correction is where they patch the VSD, they patch the stenotic pulmonary artery, they cut out any of the muscle that is obstructing the outflow tract, and they let the heart heal. And then once this surgery is done, the baby is generally fine, their child's generally fine, and they live on to have a normal life. And what has happened, or I've noticed in Guyana, is the babies that have the PDAs live, well into their 7, 8, 9 years old. And hopefully we can come and provide them the surgery, the full surgery, so that they can continue to live a full and long life and have many, many years. So the second last topic I want to talk to you guys about pacing wires and pacemakers. So we've talked about 2 lesions that require intracardiac manipulation and surgery. So going back to the normal conduction system of a heart, and you guys are probably aware of this. The heart has nerves. It's a muscle. It needs to learn how to pump. But the heart has a certain pathway that tells it how to be efficient. So I've been talking about all this efficient pump and valves opening and closing and blood going where it goes. That's great, but something has to tell it to do that. And what tells it to do that is the cardiac nervous system. Just like you have a nervous system in your spine and your head, your brain has a nervous system, and it has direction. It has certain parts telling other parts what to do. And so everything starts in the sinus node. The sinus node is up here in the top part of your right atrium. It is your pacemaker. It tells the rest of the heart what to do. So the sinus node fires and a signal is sent, and it goes down these internodal bundles, and it goes to this part called your AV node, your atrial ventricular node. And this node sits right outside the tricuspid valve on that atrial ventricular septal shelf, that septum, and then it passes through the AV node. It's a gatekeeper. It kind of says, well, sinus node's telling me to do this. Do I want to do what the sinus node says? And usually it says yes, and it lets the signal go through. It goes through into what we call the bundle of His, and then it bifurcates into 2 other bundles. So you have the left bundle and the right bundle, and that goes down the ventricle, and then it goes to the very end, and it terminates into these things called Purkinje fibers. And the Purkinje fibers are these little webs of nerves that permeate the entire spherical surface of the heart to tell it how to contract. So it goes top, bottom, and then contract, top, bottom, then contract. So it's a full kind of gloved contraction to push all the blood forward. And I'm going to add another view just for you guys to understand that it isn't 2-dimensional. This is a 3-dimensional circumferential nervous system. So this is a side view of the heart. And what you see is the Purkinje fiber, or the bundle of His, going down to the wall and then spreading out like a web around the entire heart ventricular surface to give it nervous innervation and tell it what to do. Now, we've talked about 2 surgeries that do a lot of manipulation. They're either manipulating the VSD, or they're manipulating the atria because they're cutting into it so that they can get into the heart, or they're suturing and putting patches in. And unfortunately, injury can happen to this nervous system because these nerves aren't always easy to see. The surgeon kind of has a general idea where they are, and they can see some bumps that tell them this is the atrial node and this is the AV node. I don't want to do anything here. But hearts are different. Every heart has slight variations. And sometimes, they put a suture in and it's too tight, and that tightness causes ischemia or cell death and destruction or edema, and it injures these pathways. And when these pathways get injured, the heart doesn't know how to talk to each other. The top and the bottom might not talk, or the bottom and the middle might say, I want to go faster than the top does, and the top saying to stop, and the signals are completely incongruent with one another, and an arrhythmia develops. And so we know this can happen. So the surgeon preventatively will put in something called pacing wires. And the reason why we put in pacing wires post-operatively is so that we as clinicians at the bedside can tell the heart what to do, even when it doesn't want to do it. We have a device called a pacemaker that will send signals that says top, bottom, or top go faster than the bottom wants to go, or just the top go, or just the bottom go. We can control that so that we can temporarily make the heart pump more efficiently than it wants to pump on its own because the signals are all messed up. And what the surgeon will do is once they're done the surgery, they'll put leads, which are wires. They'll put them in the right ventricle and the right atria, and then they'll push them through the chest wall so that they come outside the chest, and they have two little hookups, and we hook those up to the pacemaker. And I've seen different devices on the trip. I think the one on the left here is the one that I've seen a lot of the times on trips. This is another version that we have here in Canada. But the thing that comes is these two wires stick out of them, and you attach from the patient, the two electrodes or the leads go into this device here. And then they connect to this device, and then all the settings can be sent on this device of how you want the heart to beat. And this kind of is what it looks like in the operating room. This is the heart. This is the leads going outside the body. They go through the thoracic cavity. They sit on the tissue of the heart. And then the surgeon will connect them to this device here, which connects to the pacemaker. And when we recover the patient, we will see these out there. And it's one of our responsibilities to make sure that the patient does not disconnect from these. Because if the patient disconnects from these, they don't get any of the signal from the pacemaker, they can go into arrhythmia, their heart could stop, it could beat inefficiently, and they could die. So it's really important that these pacemaker wires be connected properly so that the patient can continue to get the signal. This is what I was talking about. So the surgeon puts the pacemaking wires in the atrium, he puts the pacemaking wires in the ventricle, and we only pace the atrium and we pace the ventricle. So the atrium is where that sinus node is. So if we send signals here, the heart should be conducting top to bottom the way we want. And if we send signals to the right ventricle, it doesn't follow the bundle of His directly, so the ECG will look weird, but the heart is capable of still sending the impulse around it circumferentially to give it a good, efficient squeeze. Now, there's a lot of different settings. You don't need to know that it's not pertinent. Just know that there are different settings. So there's settings like DDD, which paces the top and paces the bottom. It keeps them in sync. And if the patient's rate goes higher than the pacemaker lets the patient's heart rate drive the show. And if the patient's heart rate drops, the pacemaker takes over the work. Or you have something like AAI, which is just pacing the top and saying, this is what we're going to do. And then if the patient's atria beats properly, it says, okay, I'm going to wait. I'll let the patient do the work. And then if it doesn't, it will take over. And then we have something called VVV or VVI, which is the ventricle. There's no talking to the atria. It's just the ventricle beating. And we use this setting a lot in babies. And then DOO is where we just do everything. This is a resuscitative setting. And this is like where the patient's heart stopped, but they have pacemaking wires. We can hit the DOO button and just do top, bottom, top, bottom, top, bottom. Doesn't listen to the patient at all. It just keeps the heart going till we can try to do whatever has caused their heart to stop. As I said, the pacemaker can listen to the patient's heart rate and it will not do anything because it wants the patient to do the job, or it can go pace above the heart rate. The intensivist sets the settings and it controls the heart. They'll set the rate, so how fast it goes. They will set the sensitivity, which is how sensitive the pacemaker is to the patient's intrinsic heart rate. So what threshold needs to be met for the pacemaker not to work, and what threshold needs to be met for the pacemaker to work. And then they can set the output. So how much juice is necessary to fire the heart. As heart muscles get sick and edematous and inflamed or injured or scarred, it usually takes more and more output to fire that myocardium because the myocardium's sick. So sometimes you have to crank up the settings. So the key of all of this, the takeaway that I want you guys to know is the nursing considerations. So never disconnect the patient unless you've been instructed to by the most responsible doctor, be it the surgeon or be it the cardiac intensivist. Do not disconnect this patient. This patient may be dependent on the pacemaker. They may not have a suitable intrinsic rhythm to keep themselves alive. And if you disconnect them, you stop everything, and there's no warning sign to say don't. It just disconnects, and the patient can arrest. I had it when I was on a trip in the Philippines. There was an anesthesiologist who was from the local team. I have no idea why they did it, but they came and they brought the patient back from the OR. We were carrying up all their stuff. They were taking their monitor back. They were taking their bags, the settings, and some junior anesthesiologist decided to just take the pacemaker out and walk away. We were paying attention, but like not paying attention. And literally the monitor went from a paced rhythm of like 100 beats per minute to a intrinsic rhythm of 40 beats per minute. And we were like, what the hell happened? So we're thinking, metabolic acidosis. We're thinking that there's been, maybe hypovolemia, the heart's not pumping. So we're scrambling and we look and we're like, where's the pacemaker? And we're jamming around, and we had to grab one of our pacemakers that was in like one of the boxes and quickly hook this patient back up. But literally the person walked away and we didn't know where they went. And we're like, what are we going to do? And so I now am much more proactive that whenever a patient comes back with a pacemaker, I have like focus on that pacemaker, and I do not let anyone touch it, because without that pacemaker, we can't resuscitate the baby or the child. So never disconnect the patient. Second of all, never change the settings on the pacemaker. You can't easily do it. There's lockout mechanisms, but just don't change anything. Just let it be and let the intensivist or the surgeon make the settings, because sometimes they're dialed in very appropriately for the patient. And if you make a setting like turn down the rate, the pacemaker may not work. Or if you turn down the sensitivity, the pacemaker may decide to pace too fast and you get any of these pacemaker-induced arrhythmias. The other thing that you have to do is when the patient comes in, the expectation isn't you to know exactly what rhythm they're in, but you should try to make a mental note of what the ECG looks like when the patient comes back from the OR. If you have an ability to print out a rhythm strip, print one out. If you don't, just kind of keep an image, and I'll show you some pictures of what pacing rhythms look like. And if you ever know or ever think that the pacing rhythm has changed, let one of us know. Let myself or Carrie or any of the medical team know, so we can come and kind of troubleshoot what's going on, because sometimes the leads can get dislodged, they can disconnect, they can fall out. Like a lot of different things can happen, and it requires a little bit of expertise to troubleshoot it. You also want to make sure that those wires are nowhere near the patient's hands, or the patient's restrained, or the wires are tucked a certain way so they can't grab it and pull it out. And you also want to make sure that the wires are not near any equipment, any handrails, anything else that can catch on it and inadvertently pull out the pacemaking wires. They are sutured in, but when we pull the pacemaking wires out, it's not complex. We literally cut 2 knots and yank and just rip them out. So it doesn't take much to pull them out. If you were to catch it on an IV pull and just push it, it would probably tear out pretty easily. So just make sure that your area is clean and there's no beds and wires, and even tell the parents, like sometimes they need to be kind of told, like, don't go near the pacemaker or stay away or watch it, because a lot of parents want to hold the baby and cuddle them. And, we try our best to accommodate that, but there are a lot of times chest tubes and pacing wires, and it's just not safe to do. So sometimes you just have to kind of be like, well, hold off, like the baby's really sick, just hang out and make sure everything's kind of in the right place. And the one thing you can do is every time you're on and you're looking at the pacemaker, we'll do it too, is just make sure there's a full battery inside. And there's usually, even if the pacemaker is locked, there's a little indicator in the corner that says how full the battery is, because the worst thing you want is a pacemaker to die because it was a battery, which you could have easily changed. And I might make pacemakers sound really scary. They're not. They're just a lot of stuff that can kind of go wrong, and we kind of rely on them to pace the patient. In the worst case scenario, if the pacemaker fails and we don't have the ability, we can bring like a cardiac defibrillator, and you can put pads on the front or the back or the top and the bottom of the patient, and you can pace them like through the thorax. It's not as good, it hurts, it's much more detrimental, but it will be a resuscitative option. But the pacemaker wires, the temporary pacemaking wires, is just the easiest way to do it. So these are kind of a picture of what a pacing spike looks like. So the first thing you'll notice here is there's a little inflection right before the P wave. So this is when the pacemaker has sent its signal to the heart to say pace. And then you'll notice that there is a little pop-up of a P wave, because that's the sinus node responding to the signal. Then you'll have, if the patient is in a top-bottom pacing mode, you'll have a second spike. And this is your ventricular pacing wire spike. And this sends a signal to depolarize the ventricle, and you got our QRS. You'll notice that the QRS is slightly different because it is not being originated down that bundle of His, that pathway down the center. It's being originated on the outside of the right ventricle. So it kind of looks like this kind of S complex, QS complex ECG. That's normal, that's okay. But this is why you like look at it and say, this is how the patient came from the OR. This is an okay rhythm. And this is what we want to see. If the patient's being paced DDD or DDI, we want this pacing spike. This is where there's a loss of capture. So we notice here that there is a P wave, and there's a spike, and there's a spike here before the QRS, but the QRS is not looking like this. The QRS looks normal. So this pacemaker likely hasn't got capture, meaning that there are lost pacing. It hasn't been able to depolarize the heart. Either it's set to recognize this as an okay rhythm, or there is not enough output from the pacemaker to depolarize the heart we want. So if you notice that the patient comes back looking something like this, and then the rate has changed to something like this is where you would call someone over and say, hey, can you take a look? I think something's changed. And don't worry, I'm looking at monitors all the time too, so I'm there with you guys, and I can help troubleshoot you or point stuff out as well. But this is kind of what we look for, is like a change in pacing spikes. Thank you. I only have 2 more things to talk about, and then we're going to be done, guys. Thank you so much, but we're making good progress. So one of the key concerning cardiac arrhythmias that we really, really worry about is something called junctional ectopic tachycardia. And it is very, very common with TET repairs, tetralogy of flow repairs, and can happen AVSD repairs, because what's happening is there is injury to the AV node. Both of these lesions has abnormalities in that septum. Both of these lesions have surgery around the AV node. Both of these lesions can have injury to the AV node. And what happens is the AV node gets injured. The cells die, they get edematous, there's a release of intracellular contents like messenger signal chemicals like epinephrine and norepinephrine and dopamine and all these other things. And the AV node takes over, and the AV node says, I'm going to fire as fast as I want. And the atria tries to pace over it. It tries to fix it, but it can't, because usually the junctional rate, so the rate originating from the AV node, is faster than the atrial rate, which is very uncommon. It's one of the few supraventricular tachycardias where there is that much of a high, the AV rate is higher than the atrial rate, but that makes it much harder to break. And as a result, there is a loss of synchrony from the top and the bottom, which I kind of go back to the beginning of the speech, where the heart is efficient because top talks, bottom talks, top talks, bottom talks. And when you lose that, the bottom is just saying, I'm going to go this fast. And the top one's saying like, no, I want you to go this fast. But there's no real good communication. And the valves are opening and closing, and blood is going back and forth and not going to the body, and you get really poor cardiac output, and you get, shock states, and the baby is unstable, and they need pressors. And the problem is you're treating the arrhythmia, you're treating this low output state. You give pressors to fix it, but that excites the AV node more, and it makes the heart go faster, and it worsens the arrhythmia. And if not treated, it can be lethal. So this can happen congenitally, or it can come post-operatively. We're only going to talk about post-operative jet. As I kind of talked about, it is very common in post-cardiac surgery, 5 to 15%. I've seen it many times in mission trips. As I said, it's a complication of both these surgeries, and it usually presents in the first 24 hours because that's when the injury has occurred. That's when the swelling and the damage all occurs at the time. And out of the 24-hour window, we're starting to get, healing and reduced edema, and we're taking fluid off, and the heart's healing. And so it's less likely to occur after 24 hours, but the first 24 hours, it's likely to occur. And as I talked about, it's caused by injury. It can be stretching. It can be fluid electrolyte balance shifts. It can be ischemia. It can be injury, suture in the wrong place. When they're opening up the tricuspid valve to get to the VSD, they might pull too hard. A bunch of things can happen. And as I said, what happens is the AV node and the atria node are firing at the same time. And because the AV node is going so fast, there isn't synchrony between the valves, and the atria can be contracting while the mitral and tricuspid valve is closed because the ventricle is contracting and pushing back on it. And this causes the heart to lose that filling pressure or the atrial kick, so the heart's less efficient, and then everything just stops working. And I have a kind of a diagram so you can kind of understand what I'm talking about. So if we look at the left side, this is a normal conduction pathway. Everything starts in the SA node, travels down the little bundles, goes to the AV node. AV node goes to the bundle of His, goes out circumferentially to the Purkinje fibers. Good normal contraction. And as I said, here is where they usually cut into the heart to get to the inside. So injury there. Or if they're manipulating around here, they can injure that AV node and cause jet. And so what jet looks like is here. So if you see the little circle, that's where the original impulse, the pacemaker is. And in jet, the pacemaker is in the AV node, sending signals back to the atria, but also sending signals faster. And this is a faster pathway. So this means the ventricle will go faster than the atria because this is a slower pathway. So there's desynchrony top to bottom. This drives the thing. This drives the heart. And so we have to do some treatments to treat this, but we also need to diagnose it because this can sometimes look like things like SVT, which is supraventricular tachycardia, which is a big category for things like AV node reentrant tachycardia. There's like atrial ectopic tachycardia. There's a whole bunch of different tachycardias in the umbrella of supraventricular tachycardia. You don't need to know that. We just have to know that this is different than those because this needs to be treated differently. That's all you have to know. So how do we diagnose it? Well, one way of diagnosing it, if they have pacemaking wires, is we can take the pacemaking wires that are attached to the atria, we can hook it up to an AV, to a ECG machine. We take the leads and then we just clip them together and we print a rhythm strip, and we print a rhythm strip of the normal heart rate, and we get a rhythm strip of what the atria are doing, and we can just line it up and say, oh, the atria and the ventricle are in synchrony, so that means it's not jet. Or no, the atria is doing whatever it wants to do, and the ventricle, the AV node's doing whatever it wants to do. There's no synchrony. Okay, we think it's jet. Jet usually will have like a spontaneous onset and offset, and it usually can happen when like the patient's upset, or we can sometimes see if we can stop it. We can we can pace the heart rate faster than the AV node. So that's called overdrive atrial pacing. It's where we hook the pacemaker up, crank up the atrial rate to go faster than the ventricle rate. And once it goes faster, the AV node says, oh, wait, this is faster. I'm going to listen to this. And then the morphology will change and we get control of the heart rate again. Or we can give adenosine, which you might know is like to break SVT, and it cannot work. And generally when it doesn't work, we think this is jet versus SVT. Sometimes it can work, but if it doesn't work, we can be like, okay, I think it's SV node. Another thing we can also do is we can give adenosine while doing an AV study or atrial wire study, and those pictures can help us diagnose it as well. The big takeaway again from what all is saying is after cardiac surgery, the heart is injured. It's injured a lot. It's been shut down. It's been cold. It's stopped beating. It's been cut open. Anything that hurts the rate of the heart affects the hemodynamic instability and makes the heart not beat well and can lead to cardiogenic shock and death. And what we look for is the change in rhythm, but also the patient being symptomatic. So what we're seeing is low blood pressure per capillary perfusion, the elevated heart rate. They can look pale, they can look unwell, there can be a decrease in mentation. All of those happening can make us think this is jet. The confusing thing is you can be in cardiogenic shock, post-pump syndrome, all these other things that can happen after cardiac surgery that can be the same signs. So that's why it takes, some putting some heads together and getting some really good expertise from the cardiac intensivists to kind of say, well, this is what we think it is, and doing some interventions to stop it. One of the biggest interventions is just not using pressors, not using anything that makes the heart beat faster. So you say, well, the blood pressure is low, let's give blood pressure medications. You don't want to do that. In fact, what you want to do is you want to reduce the stimulation of the heart. So that's not using epi, not using dopamine, not using norepinephrine, not using vasopressin. It means correcting acidosis, because the heart, as it beats fast and inefficient, you can get elevated levels of lactate, which makes the patient more acidotic, which makes the heart not work well. So you got to correct acidosis, and that's giving bicarb or changing ventilation settings and whatnot. Then what we also do is we sometimes sedate the patient and slow the heart rate down. And one way of doing that is to give a drug called dexmedetomidine. Dexmedetomidine is a medication that when given will calm the patient and will sedate them, but it also has the effect of causing bradycardia. So it slows the heart rate down. We can then give antiarrhythmic medications to decrease the excitability of the heart. So this is your amiodarone, your procainamide, your esmolol. We can pace the heart faster so that we can say that this is how I want you to beat. And then another thing is we can just cool the patient down. Like we can either, have a cooling blanket, or you can just have bags of ice and just put bags of ice on the patient. You drop the core temperatures down anywhere from 32 to 34%. You decrease the cardiac demand. You help calm the patient down, and then they'll usually convert out of it. I have a little picture here that you can kind of see what's happening here. This is your ECG rhythm. This is an A-wire study at the bottom. And you can see these atrial wire, these are the inflections that we're looking at to see on the A-wire study. And then we want to see that there's like ventricular beats happening in synchrony. And clearly they're not, because here you have your QRS and here you have your P wave. And they're not in the right order. The P wave should come first. This is happening either right on top or right after. And it's happening here, and it's happening here, and it's happening here, and so forth. So it's showing that this is not a normal tachycardia. This is like the jet. Last topic, guys, and then we're all done. So we're going to talk about heart block. So heart block is also an arrhythmia, but instead of having excitation that causes the heart to beat fast and asynchronously, what happens here is there is something blocking the heart. Something is causing the heart not to conduct properly. And in surgery, if you cut, if you damage, you injure that pathway, the signal may not be able to go through. And this is also very common after a lot of different cardiac surgeries, that they can get in a state of heart block. So we have different degrees of heart block. So the first type of heart block is called first degree heart block. And you guys might be familiar with this already. And all first degree heart block is a prolongation of the time between the P wave and the R wave, the time between the depolarization of the atria to the time of the depolarization of the ventricle. And it gets wider. It goes anywhere. Usually it's like, oh geez, I have to think of my adult rates. In an adult, it's like 0.08 to 0.12 or something like that milliseconds. And if it gets greater than 0.12 milliseconds, we say that this is a prolonged PR interval. And we don't really do a lot about it. It can be normal. It can be like just common in the patient. It can just be there's a little bit of swelling in the sinus node. We do a whole lot of nothing on this. The only time we really would think about doing anything is if it continues after surgery, but even then we probably will not do anything because there's nothing to do. The next type of heart block that you can see is something called secondary heart block. And secondary heart block means that there has been a loss of signal from the top to the bottom. It occasionally passes through, but not all the time. And there's different types. There's something called Mobitz type 1 and Mobitz type 2. But second degree heart block means that the SA node and the AV node occasionally don't send signals through, whereas in first degree, they always send signals through, it's just slow. So what happens in type 1 is you have a gradual prolongation of the PR interval. So in the first degree heart block, the PR interval was long. Here it gets longer, 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 and then no QRS passes through. So you can see in my little picture, we have P wave, it's a little bit longer. We have P wave, it's right after the T wave, it's a little bit longer. We have a P wave, it's a little bit longer than that, but still having QRSs. And now we have a P wave, it's hidden in the T wave, but it's there, and no QRS. And then the heart starts again. So it's just longer, longer, longer. This can be caused by just like an increased vagal tone, like gagging or vomiting or being sedated or being shocked. We don't always necessarily need to do anything about it as long as it doesn't get into that there is consistently a loss of conduction from the top to the bottom. And that's where we get a little bit more worried. And that's where we get into our Mobitz type 2 or our second degree type 2 heart block. And in this type, there's always a consistent P wave. The P wave is always firing, but the heart decides to randomly not conduct a QRS. So the top's going and the bottom isn't. And this can be due to injury to the bundle of His. It can be due to electrolytes. They could have something called long QT syndrome. They can have cardiac surgery. And this we worry about. This we're worried because eventually there might be no conduction on every beat and there's no synchrony and the patient can go into third degree heart block. So if this continues, we may put a pacemaker or they may need a long-term pacemaker, or especially if it goes in the third degree. And so the last one that we're going to talk about, and this is my last slide, so you guys have gotten through all this with me, is third degree heart block. So third degree heart block is the most serious type of heart block that can happen after surgery. And what happens here is the top of the heart and the bottom of the heart do not talk ever. They never talk. The top does whatever it wants to do. The bottom does whatever it wants to do. They never listen to each other, and there is no efficiency. There is a complete loss of atrial kick. The valves can be opening and closing whenever they want. They're not talking to each other, and this can progress to death. And so it's a complete failure. There's no AV synchrony. The atrial rate can be normal because the injury isn't in the atria. So the atria can be going at 100 beats per minute, but the ventricle rate could be like 40 beats per minute. And it is not filling properly, it's not ejecting properly. And if this doesn't resolve within 2 weeks post-surgery, you need a pacemaker. There's no return. The heart rate will not return, and this person needs a pacemaker. Anyway, guys, that's a lot to talk about. If you guys like, that's a lot to process. I know you may not have a lot of questions. It might just be like, this is a lot to take over, but if you do have questions, please ask. If you don't have questions right now, you can ask me on the trip. If you guys have questions later on, you can let Carrie know and I can answer them, but if you guys have any thoughts, want me to go over anything again, tired, good, glad to be done, whatever you like, guys. Albert says, wow. So, oh, he said that like an hour ago. So I don't know what I was talking about an hour ago, but he said, wow. So I opened to that. Anyways, like a lot of this is a lot to take in. By no means I have any, like, this took me years to solidify into my old brain. Like, and, you know, I have textbooks and I have stuff that even for this lecture, I had to go through just to make sure I wasn't telling you guys lies that I just believe to be true, like actually like confirm that what I'm saying is right. But you know, it's more about being aware and having like I hope those videos kind of gave you a good understanding, because that stuff just blows my mind. Like I have been doing this for almost 10 years and this stuff still blows my mind every time to see what these surgeries can do, and I love this stuff. So I hope you can, like, this is the whole idea about having the practical understanding that you can see it in your brain of like what actually gets cut and what gets patched and what gets done, so that you can get an understanding of that. You know, your patient comes back and their chest is closed and you're like, well, they didn't do anything, they just put a line in their chest, but actually like some amazing stuff was done. And I mean, like doctors like Dr. Rodrigo are just amazing that they can do that kind of stuff. So, you know, if you guys, again, you have questions, you want to talk about heart lesions, I usually bring a couple books with me on these trips and pictures, and I got Google and stuff like that we can just like go over these kind of lesions, because I really like this stuff and I like teaching other people this kind of stuff too.
Thank you so much, Aaron. Thank you for your time and everything, lecture prep, all of it. Appreciate it so much.
Anytime.
All right, guys, until
Thank
we
you.
see you in March in person, please holler if you need anything. I will get the recording rendered and get the link over to you guys this afternoon. And I will see your beautiful faces in December.
Yes, you will.
All right. Thanks,
Oh,
y'all.
by the way, I said, wow, when he was talking about the older guy that is still alive.
Yeah. Oh, okay. I thought it was the pacemakers that when we first cut in, but yes. Okay. And I think 70 years old, right? That's impressive. That's impressive.
He has a couple, like I'll maybe I can find the article just to show you guys. Like it's not patient confidential or anything. Like he's proud of this. He's gone back to John Hopkins and got awards and stuff like this. Like I'll try to, I remember his name's like Michael, I think. I'll try to find the article and I can send it to Carrie just if you're interested, because it's like he's very proud of this. Like when I went to the Philippines, he's part of that organization out there because of how proud he is to be part of this in some little way. So yeah, it's that's the beauty of cardiac surgery, is there's these amazing stories that come out of it, and it's really great.
Yes, absolutely. Okay, have a good rest of the afternoon, guys, and we'll see y'all next month.
You too, guys.
All right, take care.
Bye. Thank you
Bye.
so much.
Thank you.